on axillary dissection. The speaker will be Dr. Ashutosh Mishra, who is the Associate Professor in the Department of Surgical Oncology at the All India Institute of Medical Sciences at New Delhi. Over to you, Ashutosh.
So, very good evening to all. Brings greetings from all the societies. Currently, I'm on board, and I am very thankful to ASI and EPSI for kind invitation. So, I am mostly my presentation will be focused on axillary dissection. So, ALND is still considered as a routine standard for patients with clinical, radiological, or pathological proven positive axilla. And also when SLNV fail or when it is contraindicated, particularly in inflammatory cancers or when central lymph nodes are 2 or more than 2. So it's in T4B breast cancer and clinically positive nodes. Management after sentinel lymph node biopsy. When there are more than 2 metastatic sentinel lymph node on SLNB, then usually we are opting for axillary lymph node dissection or 1 or 2 metastatic sentinel lymph nodes on SLNB, but who do not desire whole breast irradiations. Similarly, currently in patients 1 to 2 positive sentinel lymph nodes, adjuvant RT planned with intentional inclusion of undissected axilla, then we can avoid axillary dissection. So this is very busy slide of NCCN guidelines. There are the criteria. Here you can see clinically T1, T2, clinically N0, no preoperative chemotherapy, 1 to 2 positive sentinel lymph node, whole breast radiotherapy is planned. When answer is yes to all the questions, then no further axillary surgery. If the answer is no to any, then axillary dissection is indicated. So border of the axilla, we have already discussed superiorly axillary vein, serratus anterior muscle medially, latissimus dorsi muscle laterally. Apex of the axilla is usually formed by the costoclavicular ligament, and base of the axilla is comprised of skin and axillary fascia. So content of the axilla, we have seen in anatomy, blood vessel, lymphatic tracts, and nerves. So the dissection should be inferior to axillary vein. Thus the axillary artery and the brachial plexus are superior to surgical field. So we are not going to harm axillary artery or brachial plexus. So there are 3 important major motor nerves of the axilla encountered during axillary dissections are the long thoracic nerve of Bell, and that usually run parallel to the chest wall. Then thoracodorsal nerve marks the deep aspect of axillary space and innervates the latissimus dorsi muscles. Then medial and lateral pectoral nerves innervates the pectoralis major and minor muscle. Injury to these nerves leads to denervation, atrophy, and shortening of the pectoralis muscles. There are some sensory nerves also passes through the axilla, intercostal-brachial nerve from the second intercostal and third intercostal brachial nerve. So these are the main supplies the medial upper arm and axillary skin. Lymph nodes, we have seen level 1, level 2, level 3 on the basis of pectoralis minor muscle. So coming to preoperative preparation. So operating room safety, it's important as we do all surgical procedure, including opting informed consent and site marking. And anesthesia, usually general anesthesia, the patient should not be paralyzed because otherwise if it's not done, then you can sense the functioning of nerves. Antibiotic prophylactic should be given isoflurane, augmentin as per your institutional practice, or it should be given just before the incision. Otherwise, the efficacy of the antibiotic might be compromised. Deep vein thrombosis, if the axillary lymph node dissection is going to be performed along with some other procedure and it's taking too long, more than an hour surgery, then you can go for deep venous thrombosis prophylaxis as well. So positioning, arm should be extended on board. It should be less than 90 degree. More than 90 degree abduction, and there is the rotation of table and various angles sometimes may stretch the brachial plexus, and that may weaken the arm. Ipsilateral arm can be included in the prepared area at the discretion of the surgeon. Most of the time, it's including the field, and that help in the axillary dissection. Lateral chest wall should be positioned along the edge of the operative table, so that will help the operating surgeon to do better dissection. So surgical technique incision. So if you are doing along with the mastectomy, then your steward incision, modified steward incision is sufficient, and you can go into the axilla. If you are performing this axillary dissection separately, then you may give incision below the hairline in between the anterior and posterior axillary line, 1 centimeter usually below the hairline, 5 to 7 centimeters incision length is sufficient. So while after giving the incision or after doing the mastectomy, so first important thing is defining pectoralis muscle, pectoralis major muscle. After doing dissection along the pectoralis major muscle, and we dissect towards the axilla, identifying pectoralis minor. It runs deep to and more vertically than pectoralis major by about 30 to 40 degree of angle. The lateral edge of the pectoralis major muscle is retracted medially to expose the pectoralis minor muscles and allow interpectoral dissection of the rotor's lymph nodes. So this is the pectoralis major muscle pulled up with the help of webco. Then you can do interpectoral fat dissection and take out the interpectoral nerve. So once it is done, then you reach to the pectoralis minor muscle. So there is a role of clavipectoral fascia. Here you can see the clavipectoral fascia. It's covering the pectoralis minor muscle, and there is a suspensory ligament of axilla that's down. So once you incise this clavipectoral fascia, then you enters the axilla. And here in this picture, you can see this is the clavipectoral fascia covering the subclavius, then covering the pectoralis minor muscle, then it's attached to the skin, making the suspensory ligament of axilla. So by incising here or here, you can enter axilla, and there is differently, you can see the change in the fat granule size and content. So you can identify that we have entered the axilla. There is a giveaway type feeling while you are incising the clavipectoral fascia. So dissecting superiorly along the pectoralis minor and find the medial pectoral nerve. So make the dissection along the pectoralis minor muscle. Then you will find medial pectoral nerve neurovascular bundle wrapping around its lateral margin. So that's the point. Here you can see that's a medial pectoral bundle that's going inside. So it's the site where you can see assess that there is the vein, axillary vein. So it's a landmark. So you have to be cautious while dissecting over this. So the medial pectoral bundle, which innervates the pectoral minor muscle and should be preserved during the dissection. It's a misnomer. Its medial pectoral nerve is the lateral, and the lateral pectoral nerve is the medial. So this is a picture. Here you can see MPP, and this is the pectoralis minor, pectoralis major as an axillary vein, and that's 1 centimeter above and almost 1.5 centimeter below this bundle. So there are the different approaches. You can then do the superior medial dissection, superior dissections, or you can define the lateral border and then come over the superior and superior medial dissection. So identification of latissimus dorsi. If you are going for lateral border delineation, the anterior surface of latissimus dorsi muscle is the lateral border of axillary dissection. Here you can see the muscle. This is the lateral border. And while doing the lateral dissection, you might find some perforator that you need to tie or clipped, so that the fatty tissue of the axilla can come out of this lateral wall. So you need to preserve skin and subcutaneous tissue here, because it's a thin out, you may injure the skin. So this is the muscle. You can see this is the lateral wall fat, and muscle is beneath of that. So once this is done with care, then you can see you have identified the axillary vein, and there is a lateral wall. Then you need to do superior dissection with care not to open axillary sheath and strip or skeletonize the vein unless there is extensive nodal disease, because this increases the risk of injury to the vessel and lymphatic, which can increase the risk of lymphedema subsequently. And expose the axillary vein along its inferior boarding, noting that any vein tributary entering at right angle from below, looking for a thoracodorsal vein lying deeply. So here you can see the vein that's going directly into the axillary vein. So do dissection along this vein, separate this tissue from the axillary vein and go deep. Most of the time, thoracodorsal bundle is just deep to this vein, or with 1 or centimeter either side, you may find in the depth. So axillary vein. Dissection is carried posteriorly, anterior the axillary, and visualized with care not to open sheath. Most of the time, you may find 2 to 3 axillary veins. So if you are finding any horizontal structure that traversing the axillary fossa, then you need to preserve unless you are sure. It might be very thin in the size, but you need to take care not to ligate this. And mobilization of axillary fat, then mobilize the entire fat from the axillary vein, and always preserve transverse venous structures. Then superior medials. Once you have identified the axillary vein and you are identify the medial pectoral neurovascular bundle, pectoralis minor, then you can do the superior medial dissection. Most of the time there is a fat pad and you may find one or two nodes sitting over there that you can take out. So while removing all these fat pads, you may encounter some small vessels that are supplying in those particular areas. You may clip or ligate those vessels. So once you are doing superior medial dissection, you need to retract the pectoralis
Ashutosh,
minor.
last 1 minute. Ashutosh, last 1 minute.
Okay, sir. So level 2-3 dissection, you need to retract the pectoralis minor muscle from where you can take out the fat. So you can preserve these intercostrobrachial nerve that's just below the pectoralis minor muscle, or you can sacrifice them with the high burden disease. Similarly, long thoracic nerve, it's lateral over the chest wall and it's under the fascia of serratus anterior muscles. We need to take care while the serratus long thoracic nerve is looping. It's not close to the chest wall and apex of the axilla, so you need to take care. And the serratus anterior nerve is almost at the level of lateral pectoral nerve. So thoraconeurovascular bundle that we have already discussed, it's deep down, it's at the level of long thoracic nerve, and lateral thoracic thoracodorsal nerve is medial to the bundle. So then you need to take out the entire specimen in between both the nerves, long thoracic nerve and thoracodorsal pedicle. That should be taken out. So that should be the subscapular muscle. All the tissue has to be extracted. And there is the angular vein. That's the completion of your dissection. So in between both the nerves and angular vein, that's the idea. You can preserve all the nerves. There's the long thoracic nerve, intercostrobrachial nerves. There is the fascia over the vein, and there's the chest wall and the medial pectoral pedicle. And extent of dissection depends. We need more than 10 lymph nodes. If we are harvesting less than 5 to 21%, there are the chances of recurrence. Routine removal is up to level 3. Rarely we are go for level 3. Then put 14 to 16 size closed suction drain. Post-op care, pain control drain, physiotherapy and lymphedema is needed. Infection 3 to 15%, hematoma 2 to 10%, then seroma. So there is a lot of, while doing ALND, there are the high chances of morbidity. Similarly, there is a motor nerve risk of 1%. And I think, thank you so much.